Thanks very much for the invitation to bring me back home. Those of you who don't know me, I work in Aberdeen in Scotland, but I'm a Delhi boy for a long, long time. So it's always a pleasure to come back. And to this master series, I feel a little bit of imposter syndrome. Not a master, but still, I'll try and share my case with you. It is not as exciting, it is not as sexy as what you've seen so far, but it's good to come to friends and share your difficult problems. This is a 49-year-old man who presented to me with pain in both his shoulders. He's got multiple epiphyseal dysplasia. He's had bilateral hip replacements. He's had steroid injections both his shoulders in the primary care. And when you see him, he's short stature, you can see him from the back, and he's got limited shoulder movements bilaterally. And these were his images of both shoulders. And this is going back a long time. You see, this was 2012, when I was more naive than I am now. So anyway, so these are his images. As you can see, significantly dysplastic shoulders, deformed head, loose bodies, virtually no glenoids. And my hip colleague, he was the one who sent over to me. He had done these metal-on-metal hips, which he was doing reasonably well with. So, can I get my ARS1, please? We've got a very limited sample size, but still.
It is an interested sample, so that's what is more important.
So, nearly half will do nothing sensible, and about a quarter will go into a reverse shoulder replacement. Okay? Good. So, as I said, this was 2012. I was a bit more naive at that time. So, and I was very skeptical of reverse shoulders in 2012, doing them in 49-year-olds with such significant glenoid dysplasia. 2025 is a slightly different issue, but 2012 was different. And I would not have felt confident of putting a reverse in a 49-year-old. So in my wisdom or lack of it, I went and did a stemless hemiarthroplasty. Probably the relevant question was, some of you should have asked, was where is the CT scan here?
Yeah.
Okay. So I did do a CT scan. I could not get hold of those images. But anyway, so I did do a CT scan, and there was virtually no glenoid worth that I could implant an anatomical in. And as I said, I was very reluctant to put a reverse in a 49-year-old. So in my wisdom, I thought, you know what, we do hemiarthroplasties in young people. I was doing, for osteoarthritic young people, I would do the stemless. So I did it. And it was reasonable, position was okay. It was centered in front of the glenoid, the version is good. But at 8 months, he comes back as follow-up and says, no good. I'm still painful. You haven't improved my range of motion.
Kapil, sorry to interrupt. What was the primary complaints?
Pain and lack of movement.
The range of movements were totally...
He could manage up to about 90 to 100 degrees of elevation, and that was painful. And he had night pain. He had 2 injections. The thing is, he's had 2 successful hip replacements.
So these complaints were like from how long?
They had developed in the last few years.
Last few years.
So, and I will talk about how does a multiple epiphyseal dysplasia behave later on when we do discussion about that. But if you look at, a bit theoretical thing, there are 2 types of presentations of multiple epiphyseal dysplasia. One is the more aggressive one, in which they get a lot of problems during childhood. The other ones are who can go up to the 4th or 5th decade when they start to become symptomatic. So he belonged to the second category of the multiple epiphyseal dysplasia. So anyway.
So you saw in the CT something on the glenoid side?
But I was not, as I said, it was not good enough for me to implant an anatomical glenoid in. I have used the same system since 2012. So it's a pegged cemented glenoid. I was not comfortable doing that. And as I said, 2012, I was not comfortable doing a reverse in a 49-year-old. So I'm amongst friends. I'm just sharing my joys and grief with you. So anyway, so 8 months post-op, he has no benefit from surgery, and he comes to me and he says, what are you going to do for me now? Can we get ARS2, please? Help me, guys. Good, yeah, 60% say revise to a reverse, absolutely right option. But again, this is 2013, and I'm still not comfortable doing a reverse in a 49-year-old. So I did this. Probably an antiquated operation, and it is just to highlight that it is a viable treatment option for somebody that age, with that disease. So I went and used a femoral head allograft, and I did a shoulder fusion. If you have any comments at this stage, otherwise I'll just move on. Just out of curiosity, how many people in the audience have done a shoulder arthrodesis? I knew Dr. Bhasin will say yes. Yeah. And just for my education, your indications: neurogenic shoulders, infected, dysplastic, polios. So brachial plexus injuries. Yep. So
So
that was the only cases that I'd done it for, was brachial plexus injuries. Yeah.
So you operated only one side.
Yeah. Wait. Wait, I've just said is for my friends who don't understand Hindi that there is still more to come here. So this was 2014. I fused his shoulder and he went away. And 4 years later, he came back and said, "Yeah, right shoulder is good, no pain, occasional twinge. I'm managing very well, but my left shoulder continues to be painful. What are you going to do for it now?" So I've got a successful operation on one side. So what do I do now? And this is a CT scan. So this will give you an idea about the glenoid status. There's a significant degree of retroversion, which for me is not conducive for an anatomical shoulder replacement. So this is his fusion is pretty robust. You can see bone there. So the dilemma is the left shoulder now. ARS 3 actually, not 2, 3. So what are you going to do now? Should we just fuse him again? He's got one successful fusion. Or do I do something else? So at least half would do a
Custom glenoid.
custom-made glenoid. So yeah, so this is now 2018, 2019. I'm more confident as a reverse arthroplasty surgeon. My indications are now getting broader because I'm seeing good results, and I've got solutions that are available. So we discussed this. I think Mark presented some cases with the Biomet comprehensive VRS system. So this is a custom-made glenoid, and that's my surgical exposure. And this was in post-op. So just to highlight now, on one side he has had a fusion, and on one side he's got a reverse shoulder replacement.
How does he himself compare both the shoulders?
I'm coming to that.
Right is lifting more, the right is lifting more.
I'm just coming to that. So again, to highlight that I was never expecting that I'll get normal function even with a reverse in him. But I'm surprised that his fused shoulder is doing reasonably well. And at this stage, in 2019, he says there is no difference between the two shoulders.
Right.
There is not one he would choose over the other. In July 2020, he underwent a lap cholecystectomy. I don't know what they did, but he was discharged, and 6 weeks later, he pitched back at my clinic and said, "I've got pain in my right shoulder now." So I don't know what they did in his lap cholecystectomy, but he developed pain in his right shoulder. I sent him away. I said, "Okay, fine, it will settle down." In 2023, he came back. He still has pain in his right shoulder. The fusion appears still solid. I sent him for a CT scan, but he doesn't want to undergo a CT scan because he's now developed claustrophobia. So he will not go into a scanner.
Oh,
So now my dilemma is, where is his right shoulder pain coming from? And I don't know the answer. Maybe those of you who've done fusions before, is his fusion, was it going to happen? So I've sent him to the pain clinic at the moment, but yes.
Was there any subdiaphragmatic action? In view of
No, he made a good recovery after his cholecystectomy, but I presume there was some irritation there. But when he came back, the surgeons were happy. There was no issues with his abdomen, but he had pain in his right shoulder.
Scapulothoracic bursitis and those joints, because the movement is now occurring at the scapulothoracic joint. Probably that is the cause of discomfort.
So the movement is really good. I was just wondering whether the shoulder was really united.
Yeah.
Because it looks not healed.
Yeah,
Bony.
I take your point, but if you go back to the,
Also in the first X-ray.
so I've got,
The first X-ray you showed us.
yeah, the X-rays, but the CT there shows that there is bridging bone across. And I've thought exactly the same what you're telling me, but I've always felt that if there was abnormal mobility at any of these screws would have become loose. These are now 11, 12 years down the line. There is no lucency around these screws. So I'm thinking that that is a surrogate marker that the fusion is solid. Because if there was abnormal mobility there, we would have had some issues with these screws. So I fused them back in 2013, and this is now 2023. So there has been no change in the position of the screws, but that was my concern, yeah.
Kapil, was there any tender point? Where was the tender point?
There was no tenderness. No, there was no tenderness.
The pain was deep-seated or was it a
It's deep-seated. Yes. He's 13, 12 years now down the line, you see, so. Yeah, he did fine. Mark?
I agree. I think all of these patients eventually get scapulothoracic pain. That's the problem with these fusions. If you leave them, it might just be a coincidence that it happened after his lap chole, but I think that's where I would go for the investigation.
Actually, someone just mentioned or asked if there was pain locally in the shoulder. How high was your suspicion of the origin of the pain coming from the shoulder?
So for me, my sources were whether he has got pain coming from his neck. He's got abnormal mechanics of his shoulder, so it's a pain coming from around the shoulder. So I wanted to scan his neck and his shoulder, but as I said, now he's claustrophobic, so he won't go for a scan. So my only alternative has been, there's no neurological issues, it's pain. And then when you look at the literature, as Mark just said, they do develop pain. At some point of time, the fusion is not always absolutely successful, especially somebody who's got reasonably good range of movements. So I'm still struggling to find the source of his pain.
Because it's been described as a result of a laparoscopic procedure due to the swelling with the air. To have shoulder pain irradiating to the pain after a laparoscopic surgery procedure, so maybe that could be the origin of the issue.
So I just looked at the literature for, is there anything suggestions on how to manage these dysplastic shoulders? And this is all I've been able to get. So there is a case report which was, I think, last year, doing an anatomical shoulder replacement, but there's no other paper. This is generally with people with osteochondral dysplasia by Sanchez Sotelo, and this is a review paper in the Journal of American Academy, but otherwise there's not much written in the literature about management of these dysplastic shoulders. But if you guys have any experience, I'd love to hear from you as to what you have done and what you've done differently. Probably if I saw this patient in 2024-25, I would have done a custom-made reverse on both sides rather than fusing him. But in 2012, I didn't have the conviction to do a reverse in a 49-year-old. So in summary, I think the challenges that you face with these patients is, of course, it is short stature, the bone stock is not as good, the soft tissues are there, but they are not functioning normally. And of course, if you've got a bilateral issue, which you will have in in multiple epiphyseal dysplasia, it is a challenge. But again, to highlight that shoulder arthrodesis is a forgotten operation, but it can still work and give you reliable function, especially in the younger high demand patient. And nowadays, I think reverse shoulder bespoke arthroplasty is possible. Long term, probably okay. Still, would you do it on somebody as young? I don't know. Thanks very much.
Thanks, Dr. Kapil. give us some tips on how to do a good shoulder arthrodesis, and what are your tips? Have you ever converted any of your or other colleagues' infected reverses to arthrodesis? How easy or how difficult it is to arthrodese the shoulder in these situations?
Dr. Basina's got a comment first.
I would do it arthroscopically now.
Right.
Arthrodesis is this type of.
Can you please pass on? Can somebody please pass on the mic to Dr. Basina, and we'd like to know more. Sir, can you please speak into the mic?
It's much better to do it now arthroscopically.
Okay, just like an ankle arthroscopic arthrodesis.
Yeah. And it's much better to position and much easier to position to put screws across.
Right.
Although that's a very precarious fixation, nothing as compared to the two plates. One plate I have had it broken. So 2 plates is a good option, but arthroscopic is probably much less traumatizing and a good option.
Yeah, so while I agree that technically you'll get good denuding of the cartilage, but you're probably just going to get 2 compression screws.
That's the only.
So that does concern me.
Yes.
Thankfully, to answer your question, Raju, I'm not an expert on shoulder arthrodesis. In my whole career, I've done 4, and none of them have been for failed infected arthroplasty. The others have been for neurogenic conditions or in a young person with multidirectional instability where you can't find a cause.
Yeah.
So how do I do it? Again, it is, having done 4 or 5, you don't become an expert in doing an operation. But essentially, I go through an incision through the back, over the spine of the scapula, over the acromion, down the lateral aspect of the humerus, split the deltoid, but also reflect the posterior deltoid, excise the cuff here, denude the cartilage, but make sure that you denude the undersurface of the acromion and the top of the humeral head as well, because you don't want glenohumeral arthrodesis, but you want to fuse it under the acromion as well. Then you put in 2 plates of one. You bend a plate at about 90 degrees over the spine of the scapula and over the lateral part of the humeral shaft. You'll be mindful that you go under the axillary nerve because you don't want to damage the axillary nerve. Even if it's a neurological patient, you don't want to do that. And then you put a plate across the posterior aspect as a secondary buttress, and you make sure that you've got 2 screws going from the acromion into the humeral head to get that compression, and 2 big large cancellous screws from lateral to medial to achieve compression across the glenohumeral zone. Position, I think position is very important. If you look at the history of arthrodesis, when it started, they said about 40, 40, 40. I think that is too much. So I've fused them in about 20 degrees, 20, 20, and 20. So 20 abduction, 20 elevation, and 20 internal rotation, which allows them to take their hand to their mouth, but also brings them back to the side. That's important. Function is reasonable.
Another thing, we do the same thing arthroscopically. Acromio-humeral arthrodesis. Do the same screw, raw the undersurface of the acromion, raw the greater tuberous area, and then fix the 2 through the screws. That's the same thing.
So you said.
Before you, Pratap, there's one question, and after that, Pratap.
So you said that your threshold for doing a reverse shoulder replacement has decreased over a period of years. So what is the age? What is your cutoff below which you will say, I'll still do something else, not a reverse shoulder?
I don't think I can define an empirical age on where I would or not do a reverse replacement. The youngest patient I've done a reverse shoulder replacement is a 35-year-old girl who's got significant seronegative juvenile arthritis. She's got an elbow replacement. She's got a very bad shoulder, and there are not many options. I've done a reverse shoulder replacement. I think if we look back, and there are people in the audience who've been doing reverse shoulders for as long as they have been doing. When we started off, there was this thing that if in 7 years the deltoid is going to fatigue, and in 7 years everything is going to go, so you don't touch a patient with 70. We have seen that doesn't happen. I've got patients on more than 10 years follow-up with the old-fashioned grandma delta prosthesis who are still doing fine, who are happy, satisfied. There is a little bit of deterioration of function, I think, over time, but that happens with everything. With age, we are all going to deteriorate. So is there a cutoff that I would not do it? No. If I'm doing it somebody under the age of 65, now you can see the worldwide trends, even for osteoarthritis with intact cuff. There is a multi-center trial going, which is now going to say, even with the intact cuff, just do a reverse shoulder replacement. I don't agree with that. I've got great results with anatomical shoulder replacement, so I won't do it. But I can't define an empirical age.
Pratap?
Kapil, I have done a surgery in a dysplastic shoulder. But At a 49-year-old, will you consider building up the glenoid first with the graft, correcting the retroversion or version, and then going for a second stage as an anatomical shoulder?
Yeah, so
Younger patient.
yeah, I take your point, but if you look at the glenoid, that's a very retroverted glenoid. The problem is that is the normal anatomy for the patient. I don't know if I correct that version, what's going to happen to the soft tissues and the cuff length. I don't know that. And while theoretically it seems absolutely fine to do it, but personally, if I had to do it now, I would do a custom-made metal bespoke glenoid and do a reverse shoulder replacement. I'm more confident with that than doing an anatomical with doing grafting the glenoid.
Thank you. The problem is the patient's expectation with the bilateral anatomical shoulder, hip, and they will be thinking, okay, we'll be getting something like that, isn't it?
Yeah, that's okay. The hip surgeons can get away with 25% hip movement. You see, we can't. So.
So one more.
Sorry.
So we looked at the results of reverse shoulder replacement over 22 years in New Zealand in patients under the age of 55. And we actually found that they do get a very good result, but not as good as, say, the older patients, the 70-year-old or the 75. But the reason why they don't get as good a functional result is because they're extremists. So they're having an operation at that age because there's no other option for them. But they still get a good result, and their long-term results are good as well. So they don't tend to fail. They don't get any of that weakness or any of that stuff. And then on the other thing about a dysplastic glenoid, which you could try now, which is becoming very popular in Australia, is to do a hemiarthroplasty with a pyrocarbon head as an interim measure. So you do, because the dysplastic one is facing central within the glenoid, although it's significantly retroverted, if you do a hemiarthroplasty, or even if it's a B2 glenoid, so we're starting to do a lot of hemiarthroplasties with pyrocarbon heads. And the pyrocarbon seems to be a little bit softer, that doesn't erode the glenoid. And then you don't lose the option of coming back and then putting in a glenoid later on, or even doing a reverse. And the results seem to be okay at the moment. In Australia, they've reported fairly good results.
Yes, I think the point about pyrocarbon is interesting, because I used to, so the replacement that I has got a ceramic bearing surface, and I've done hemis for ceramic bearing surface in the past for avascular necrosis, and they've done very well. So I'm not sure here, even if I'd done a pyrocarbon bearing surface with that degree of dysplasia in the glenoid, would he have done any better? I don't know.
I've got a case exactly the same as this waiting for me when I get back, and I'm doing exactly what you did. A custom-made, bespoke reverse.